Please come.
Should I start? Good morning, one and all. I'm Dr. Tithi, and I'll be speaking on treatment outcomes in extraocular retinoblastoma and its correlation with the pattern and extent of spread. Now, in developing nations such as ours, children affected by retinoblastoma have considerably lower survival outcome compared to developed nations, largely attributed to the higher incidence of extraocular retinoblastoma in these regions. The current staging systems, that is the IRSS and TNM, are most widely adopted presently. In the International Retinoblastoma Staging System, orbital RB corresponds to stage 3, and extension beyond the orbit is a metastatic stage 4 disease. However, the extent of orbital involvement is not further subcategorized. A clinically aggressive anterior fungating mass with tumor extending transclerally up to mid-orbit is categorized in the same stage as this child who has no extraocular signs clinically, but on imaging showed optic nerve invasion till the apex, thus having a much poorer prognosis in comparison. So we have to ask ourselves if the clinical radiological findings correlate with the prognosis. A similar fallacy is found in the TNM staging system where orbital RB falls in T4A and 4B category. In clinical practice, however, advanced optic nerve involvement without anterior signs, a category 4A in TNM, shows much poorer prognosis compared to an anterior fungating mass, which is T4B. In both these staging systems, the pattern and extent of tumor spread and their correlation with survival outcome is not addressed. So through our study, we aim to address this limitation by evaluating the pattern and extent of orbital involvement on imaging and correlating the set findings with survival outcome in these patients. In this retrospective observational study, we included patients who were diagnosed radiologically as extraocular RB, who had a good primary imaging films which were available for reevaluation, an available staging workup data, and a known follow-up status. Our expert neuroradiologist reviews the scans of the children and categorizes the tumors based on route of extraocular spread, that is whether it was scleral or optic nerve, and the anatomical extent of involvement was graded as follows. 0 depicts nil involvement via the said route. S1, 2, and 3 depicted involvement of tumor up to anterior 1/3, middle third, and near total orbital involvement. In tumors involving optic nerve invasion, N1 was intraorbital involvement, N2 depicted involvement up to intracanalicular optic nerve, and N3 was extent beyond the intracanalicular part. These are some of the scans with their respective S and N extents. The findings varied from isolated scleral breach, isolated optic nerve thickening, and various permutations of combined involvement. The demographics of the 45 children are as depicted, and these were the most common presenting signs and symptoms. While there were 8 cases each of isolated optic nerve and isolated scleral extension, most cases showed a combined spread pattern. This table depicts the distribution of 45 patients based on their S, that is scleral, and N, that is optic nerve severity from 0 to 4, along with the survival outcome. The S and N categories were grouped in increasing order of severities, and level-specific death rates were calculated for each category. It is clear that even though the existing staging systems place all these patients in a single category, there's a large variation in the level-specific death rate, ranging from 6 to 50%, based on the anatomical extent of the tumor, even within the same group of orbital RB. Thus, a one single fit is not valid for all the patients. The graphical representation of the same proves that all scleral and optic nerve are not the same, and death rate rapidly escalates with increasing scleral and optic nerve extent severity. So a novel imaging-based system subcategorizes a large pool of extraocular retinoblastoma, thus helping prognosticate better. Higher the S on N extent level, more is the mortality. This subclassification will help us break this large group of extraocular RB into smaller division, which the current systems fail to address. Incorporating this radiological extent-based system into clinical practice may aid in risk stratification of patients for future clinical guidelines and help personalize management based on tumor behavior. Further multicentric studies, of course, are needed with larger cohorts to validate the system and explore its application in diverse clinical settings. Thank you very much.
I think a very novel paper because this is something new. In literature, has there been any similar grading or subgrading of
No,
orbital
sir.
spread? And if gun to your head, which is worse, a higher S or an higher N?
So we are a higher N is definitely
Worse.
because we have seen in anterior fungating masses there might not be posterior extension to the apex or to the optic nerve. It's mainly a fungating in transferring through the scleral spread.
Right.
But they have a better prognosis.
So also you included only survival, or whether they were surviving or whether they were dead.
Yes, sir.
Did metastasis, distant metastasis, have a correlation with S or N?
So in our case, in patients presenting with overt metastasis, we have excluded them because by default we have mainly included orbital RB
Without metastasis?
without metastasis on imaging or without overt signs of
Okay.
metastasis.
All right. So maybe that could be your next step, where you expand all cases of orbital
Yes.
RB and see which ones have more mets, whether it's S or N.
Yes.
Thanks.
Yeah.